Sue Darcy from the Gray Sheet. I had a question for Peter Newman. You were talking about MIPA and how CMS interpreted MIPA as giving them permission to do cost analysis studies. But now we have this new healthcare reform law. And as Stephen Northrup just pointed out, 4 or 5 pages, it says, thou shalt not do cost analysis studies. So isn't it dead now for Medicare? Can't they no longer do cost analysis studies?
Well, it's a good question, and I think it's going to really matter on what's in the legislation, the precise wording, and the interpretation of it. So I guess in some sense, stay tuned, and we'll see. It's not immediately obvious that it overturns what CMS can do with MIPA. I mean, it may be that the language says, and Steve, you could flip through and see if you could find it. It may well be the language has implications for CMS's ability to use information that comes out of this patient-centered organization. But that still does not, it's not immediately obvious that then means that CMS ignores MIPA. Those things potentially at least can coexist.
So healthcare reform does not trump.
Well, we would need lawyers and people who are smarter than me and more knowledgeable to really parse through the language and answer your question precisely. So I guess we'll have to wait and see. But MIPA, I think, was pretty specific. MIPA said a number of things. CMS could start covering prevention on its own. It could never do so previously unless Congress added prevention. The prevention had to have an A or B rating from U.S. Preventive Services Task Force, for example. That comes out of MIPA. As far as I know, that's not overturned in health reform. Health reform says other things about prevention. Well, we know. So, I guess we'll have to really parse the language and see.
Dr. Newman is correct. I mean, and I've got the language here in front of me. I think the door is still open to Medicare looking at cost. I mean, they can certainly look at whatever comes out of this Patient-Centered Outcomes Research Institute. They can use the evidence. I'm looking at one section here on page 1684. If such use is through an iterative and transparent process, which includes public comment and considers the effect on subpopulations. And the only denial is the Secretary can't deny coverage under Medicare solely on the basis of comparative clinical effectiveness research. So how one then determines whether it was solely on the basis or partially on the basis, mostly on the basis. That's why this is such a great thing for lawyers, this bill.
I'm talking about cost analysis, because I know that in Congress they spent hours arguing about this. There were several amendments that said you can never use it.
And those amendments weren't adopted. There are provisions limiting the use of quality-adjusted life years. That amendments that sort of get all around the perimeter of that issue without addressing the issue completely, because I think Congress and the administration did not want to tie their hands in such an explicit way, but wanted to have plenty of things to point to make it look like their hands were tied.
So for those of you that have good memories, you might remember back to about 9:10 this morning when Alan Garber said the really heavy lifting is about to begin, which is the rulemaking process. And what you've just witnessed is a discussion that, number one, keeps people like Steve in business, actually both Steves, Steve Ubel and Steve Northrup, and really gets, because there's no simple declarative sentence like, if your kid is under age 26, they shall be allowed to stay on your policy. I think we just need to wait and see, and I think that this is, just one of the myriad of things that, as Alan pointed out this morning, is awaiting clarification, and that's probably a good thing.
Thank you. Jack Calvertinis with Covidian. And I too appreciate that both Steves still have their First Amendment rights, especially during these times, since there are so many things that are coming up that are potentially of concern. One of those things that I wanted to get your thoughts, whether you see it relating to this, is the device registry, which thankfully the industry, Steve's team helped to keep from being part of the final bill. But some of us, when it was being debated, were worried about if a national device registry were to be implemented, that could have some very negative impacts, especially if the FDA, the federal government, decided to use the information in there to start to do things like comparing costs, comparing prices that companies like ours charge together with what they deem to be the effectiveness of those devices. So what are your thoughts on it? Do you think it's coming back? Do you think it's dead?
Look, Jack, no issue truly ever goes away in Washington. They just lay dormant for a while, and I think that's certainly one that will be back. I think there'll be an opportunity for it to return when Congress takes up its, I'm not sure what the word for every 5 years is, but whatever that is, the ritual of renewing the Medical Device User Fee Modernization Act, which is now on the same track as the Prescription Drug User Fee Act. So I see next Congress as the Congress of a lot of attention to drug and device safety issues, and so as and particularly because Congress, the last Congress to take up the PDUFA and MDUFA reauthorization, PDUFA 4 and MDUFA 2, I guess. That was really all about drug safety. Remember, that was in the wake of Vioxx and assorted other issues in the drug industry. I'm not saying that, I will say that I think there'll be just as much, if not more, attention on device safety in the next Congress because the last round of reauthorization was about drug safety. So, and there are a lot of people who have felt that the device industry hasn't had a tough enough look in quite some time. So I could see this issue coming back up, but not necessarily in the context of health reform. I think in the context of the MDUFA reauthorization and more attention to seemingly to device safety in the next Congress.
Other comments? Steve.
Question for Peter. Have you looked at the governance of the new entity? I was interested that you did a study looking at the European HTA agencies.
We did look at, in that paper I mentioned, 14 agencies around the world and a bit on governance in terms of sort of where it sits in different places. Typically in the European cases, and especially it sits within a Ministry of Health, within a government. I don't know that there's another example, maybe there is, not coming to mind, where we have something like this new entity that is sort of this different being altogether. So I don't know that we have a lot of precedent for it. Trying to think, I'll maybe think of it in the taxi on the way to the airport. When comparative effectiveness and the nature of this institute were being debated, we had people offering up models from other sectors of the economy that might give us some sense of how it might operate. And it was never clear exactly what the right parallel was. So people pointed to, the Institute of Medicine or the Fed or, the Lawrence Livermore Laboratory, which is a kind of private, federally funded center. The Fed and the IOM obviously different, but they sort of sit in an independent place and try to draw some inferences from those. I'm not sure it was that helpful, except they, I think, tended to conclude it's a bit more protected from the appropriations process and the political, daily craziness. And so I'm not sure I have much else to add, because I'm not sure we have a lot of other examples that are doing this kind of thing. And if they are, they're not coming to my mind.
Other comments or questions? Well, I think then what we'll do is try to buy some time. I want to thank both Steve Northrup and Peter Newman for their comments and their presentations.